Okay, so surface anatomy of the upper extremity. And just to give everyone a little perspective, the reason we are focusing on surface anatomy is clinically, when we are working with patients, this is what we can see, what we can palpate. Obviously, in our anatomy textbooks, we can see all of the detail of where muscles originate and where they insert. But once we take that textbook knowledge, we need to apply it to patients, so the surface anatomy portion is very important. So we'll begin with the scapula, and we will start with this inferior angle of the scapula. So I like to put that right in the web space of my hand. So here my index finger would be on the medial border of the scapula, my thumb would be on the lateral border of the scapula. And then as we come up here, we find the spine of the scapula, which as we follow that along, it becomes the acromion. And so very important landmarks here. And now we'll have Kristen spin around so we can have an anterior view. And I'll now switch to the left arm. So with the humerus, we have the bicipital groove. Very important landmarks here, and sometimes difficult for students to locate and palpate. One of the things that's important to do is orient ourselves. Obviously, the bicipital groove, the biceps brachii, that muscle belly will become a tendon and will go right in the bicipital groove. So when we're palpating this, at times the common mistake is to be too far lateral and to be palpating fibers of the deltoid thinking that we are in the bicipital groove. So visualizing the biceps coming up to that groove, that's where we can make sure we're oriented correctly. So if Kristen were to contract her biceps, I can feel that biceps brachii and follow that up and know that I'm in the right space. So if we're in the bicipital groove, and so we can cradle our patient's arm, let them relax and move them into external and internal rotation, and then we can feel that bicipital tendon move under our fingertip. So if we move lateral, we will be on that greater tubercle of the humerus. And if we go a little bit medial, that's in the bicipital groove. If I move her into external rotation, I can now palpate the lesser tubercle of the humerus. And that's how I know that I'm oriented correctly. So then as we follow the humerus down, as we can see on the skeleton here, and I highly recommend that we study this way, either with an actual skeleton or a bone model, or with pictures of the same. When we're palpating a classmate or a friend, we can use the skeleton to help us know that we're on the correct location. So the humerus, as we move inferiorly, as you see on the skeleton, it flares out. And so we have the medial supracondylar ridge and the lateral supracondylar ridge, both of which really become the epicondyles. So we have the medial epicondyle here and the lateral epicondyle here. And then we get into the cubital fossa. The biceps muscles and the other elbow flexors come in this area and find their insertion. If we find that biceps tendon, just medial to that is the brachial artery. Very important, we will be learning how to take blood pressure. This is where we will place the sphygmometer to auscultate and hear that those important sounds as we inflate the cuff, and those sounds go away, and as we decrease the pressure on the blood pressure cuff, we can hear those sounds return. So in the cubital fossa, important area there. And then we follow down the forearm. Really important to recognize that the radius is in anatomical position lateral, and when we go into pronation and supination, it's the radius that's moving relative to the ulna. So right now the radius is lateral. We go into pronation. Now it's more medial and crossing over the ulna. And so when we follow the radius distally, we have that radial styloid process. And the same with the ulna. As we follow that distally, we can find that ulnar styloid. So those are two important bony landmarks. So now we will have Kristen spin back around again, and we will look at some of these muscles that are in the shoulder area. So as we oriented ourselves, inferior angle of the scapula, spine of the scapula. So superior to the spine of the scapula, we have the supraspinous fossa, and inferior to the spine of the scapula, the infraspinous fossa. So important areas here in that supraspinous fossa, we have the supraspinatus muscle, which the muscle belly is right in this area and goes down and finds its insertion on the greater tubercle of the humerus. Below or inferior to the spine of the scapula, we have the infraspinatus muscle and the teres minor muscle down a little bit lower. Both of those travel outside of the glenohumeral joint to find their insertion on the greater tubercle of the humerus. And also so this is the scapula. On this anterior surface of the scapula is the subscapularis. And now this muscle will originate on this anterior surface of the scapula and go deep to the glenohumeral joint and find its insertion on the lesser tubercle of the humerus to be an internal rotator of the shoulder. Both of these two muscles we talked about, the supraspinatus, infraspinatus, actually three muscles, and the teres minor, they all come outside of the glenohumeral joint to insert on the greater tubercle of the humerus, causing external rotation of the humerus. So very important to understand how all these muscles work, and we'll show you real quickly on our model. Removing the deltoid, a very painless surgery. And so here we see the infraspinatus and the teres minor muscles, and they come around the outside of the glenohumeral joint to insert on that greater tubercle of the humerus. And here we have the teres major, which also dives deep to these muscles, comes on the underside or the inferior portion of the glenohumeral joint to insert on that medial tubercle or that lesser tubercle of the humerus to cause internal rotation. Okay, so as we now move through these muscles, we'll have you spin back around again. I think we did all those scapular muscles. So for the elbow flexors, we have three muscles which help with elbow flexion. The biceps brachii, the long head, as we said, comes up through that bicipital groove, and that muscle will insert on the supraglenoid tubercle of the scapula. So that's where that long head of the biceps will come up and find its insertion there. The small head of the biceps, or the short head of the biceps, will go to the coracoid process for its insertion. So those two muscles help with elbow flexion. And then we have brachioradialis and brachialis. So as we will talk about with manual muscle testing, these muscles all help with elbow flexion, but they do have implications as far as the position of the forearm in pronation or supination. So the biceps brachii inserts on the radius, and so when we're in the supinated position, that's how we can do our best to isolate the biceps brachii for elbow flexion. The brachioradialis inserts also in this way on the radius, and so it will help with elbow flexion in this neutral forearm position. And the brachialis, because of its insertion on the ulna, we can do our best to isolate it by having the patient in a pronated position to perform elbow flexion. So important to recognize all three of these muscles help with elbow flexion, but they have their maximal mechanical advantage, if you will, depending on the position of the forearm. So then we go to the forearm muscles, and just in general with wrist extension, we have two main muscles that help with that. We have the extensor carpi radialis on the radial side and the extensor carpi ulnaris on the ulnar side. So both of those will help to perform wrist flexion. If we have the patient do wrist flexion with radial deviation, that will isolate more of the extensor carpi radialis. If we do extension with ulnar deviation, that will focus a little more on the extensor carpi ulnaris. Same is true for wrist flexion. We will have the flexor carpi radialis on that radial side and the flexor carpi ulnaris on that ulnar side, both of which are helping with elbow flexion. So we're going to, do you have a palmaris longus?
I actually think I do have one on this side.
So we'll have Kristen approximate fifth and first digits and do a little bit of wrist flexion, and that's where you will see that palmaris longus tendon right there. And so another muscle that we can find pretty easily with surface anatomy. It's important to note that most of these forearm muscles have muscle originations proximal and a long tendon before they find their insertion. So often when we're palpating the muscle belly, it's going to be much more proximal for these, and then the insertion will be more distal in their locations. And of course we have flexor digitorum longus, which will go to all the distal phalanges, and flexor digitorum superficialis, which will go to the more proximal phalanges. Same with on the extensor side, extensor digitorum longus will go to these distal phalanges, and so that will be a way to kind of differentiate where those muscles insert and originate. So an important point when we're talking about surface anatomy that we really need to understand as we apply this anatomical knowledge in kinesiology and musculoskeletal coursework is how a muscle gets from its origin to its insertion and the orientation of those muscle fibers. So as you're studying and visualizing and practicing, make sure that you are very aware of where a muscle originates, how it gets to its origin. Another muscle important to talk about is the serratus anterior, sometimes a challenging muscle to visualize and understand, because this will have you come over this way a little bit, camera woman. The serratus anterior will originate on the lateral surface of these ribs, and then as they find their insertion, they will dive deep to the scapula and insert on that medial border of the scapula. So if you can envision these muscles coming off the ribs and staying along the rib cage and coming to this medial border of the scapula, when they shorten, they're going to perform that scapular protraction. And so another important tip when you're trying to study all this, visualize and understand the muscle's origin and its insertion, and when that muscle shortens, what will be the action that occurs. So obviously with all these elbow flexors, origins up here, insertions down here, when they shorten, it causes flexion of the elbow, and so forth with all the other muscles. And so we'll end it with that.